Hi, my name is Trina. I am an educator in the respiratory care department, and today we're going to talk about a lung disease called emphysema. So, emphysema is something that we've all heard about, but I don't think a lot of people really know what it is. Most folks would refer to it as a smoker's lung, those people that have a smoker's cough. And the reason that we talk about it being related to smoking is because that is the number one cause of emphysema. Emphysema can be a long-term chronic, so it means that it's never actually going to go away. Long term, it's progressive, and so over time it will get worse or more severe. There are many ways that we can develop emphysema, and typically it's environmental exposures from the workplace, people that have been exposed to chemicals or smoke or different factors that would affect how their lungs respond to those environmental factors. Childhood, lots of times kids are exposed to secondhand smoke, and this can actually affect them more severely than if they were to have smoked themselves. As a child, you're not able to control your environment, and so sometimes those exposures are detrimental to your health in the future. Geographical location, meaning where are you? Where are you in space? Where are you in your neighborhood? Where are you housed? Everything like that would also play into the likelihood that you would develop this progressive and chronic disease. So as we're looking at the anatomy here, we see the windpipe or the trachea down at the bifurcation, so where that airway splits into two, it then leads to the lungs. We have the left and the right, and these tiny little airways, at the bottom of them, there are these little grape looking kind of pieces, and those are the air sacs that will actually exchange the gases that we breathe in, and also helps us to blow off something called carbon dioxide. So that's a waste product that we as our bodies are processing different gases, mainly oxygen and then environmental gases. We will then excrete the gas through those as well. And so it's where we do the exchanging. So all of you have been given 2 rubber bands. And what I want you to do is to take the brand new rubber band. I want you to stretch it. I want you to play with it. I want you to see the many different ways you can manipulate it and see that it keeps coming back together. Okay? Right? There's just tons of elasticity. Now, go ahead and pick up the older, darker rubber band. I want you to try and do the exact same thing. It snaps. Some of them are splintering, others are snapping right away. And that is because the second rubber band that you've picked up has had exposure to different temperatures, different environments, light, dark, all the different things that could affect elasticity of that rubber band itself. Our lungs are exactly the same way. The different things that we expose our lungs to are actually detrimental to the elasticity or compliance of our lungs over time. The alveoli, which are those tiny little air sacs we talked about, those little grapes, can become very rigid, so they're non-compliant. They're not easily usable, all right? And because of this, it creates inflammation in the bronchioles, which are the splitting areas into the lungs. And because of this swelling inflammation, it will increase sputum because the body is trying to take down that inflammation. If we are to look at a healthy lung, so your brand new rubber band that was very compliant, that allowed you to stretch it and maneuver it and twist it. We see that, like a rubber band, the lungs are resilient, typically pink in color, and they're sponge-like material. They're able to exchange gases, air, oxygen, and carbon dioxide. A damaged lung, we can see that right here, is a lung that has been exposed to all those different elements that we talked about. It's like a sponge that you use to scrub out pots and pans. It's just, there's holes in it, and it's very greasy, dirty. It's held on to all these different kind of toxins, and in the body it does the same thing. So, to recap what we just talked about, damaged alveoli are rigid, so they're non-compliant. The inner walls of these little grapes that exchange the gases are weakened. Let's go back here. And they're not able to do what they need to do, whereas a healthy lung is able to do that. Those air sacs, if blood flow is affected, they can't fully exchange and oxygenate the source gas, and then that prevents it from putting it out into the rest of the body, because the lungs take regular venous blood, so from the veins, it enters the lungs, they're oxygenated, all those different capillaries, all the vessels, and then it's dispersed into the body. And so venous gas is not oxygenated. Arterial gas is. Okay, so that's the blood that's in our arteries. That's why those are pumping so much harder, so much faster, because they're oxygenated, and that blood needs to get to the rest of the body. So the cilia, this is a total kind of magnification, but they're these tiny, tiny, tiny little hairs. It's like our arm hair, right? So if you feel your arm really gently, you can feel that we are, of course, we're mammals, we're covered in hair. But going like this, you can't really feel it. If you very gently feel your arm, you can see that we have all these tiny hairs. And so the lungs are the same in the sense that they have cilia. These little hairs are just like our nose hair, where they filter and they move dirt and toxins, physical toxins, away from the areas that need to do that gas exchange. If these are affected, whether they're damaged, or sometimes smoke will paralyze cilia, they can't do that sweeping motion, which means they can't get rid of the mucus, they can't get rid of the dirt in the lungs, and then it creates more problematic effects, namely likelihood of infection is increased. Mucus, like we talked about, maybe you're familiar with these little green guys, the mucinex guys. Because our cilia are affected very easily, like I said, with the smoking, they can become paralyzed. They can't do the job that they need to do, which leads to collection of fluid, and typically that's in our lower airways. So we have our upper airway and then our lower airways, and that is where the fluid collects, because we work with gravity, right? And so because of that, the body says, oh my gosh, this is going on. I need to go there, attack it, and try and resolve the issue. And it does that by creating mucus, in the hopes that this mucus will carry out the toxins. So COPD, emphysema falls under this kind of umbrella disease called COPD, chronic obstructive pulmonary disorder. It's a leading cause of death in the United States, and you hear about it all the time. Asthma is a form of COPD, bronchitis is a form of COPD, and emphysema is a form of COPD. But they're all different disease states under the umbrella of COPD. So who's at risk for developing COPD? People that are more advanced in age. Again, as our lungs and any other part of our body ages, We are not able to utilize them as effectively as when we were children. We think about immune systems and how as we're older, we're not able to fight off infection as easily. That's because over time we've exposed ourselves to the various different toxins and different elements that have entered our bodies. Family history, people say, oh, it's genetic. I got asthma because my grandma had asthma or my mom. That's a real thing. You can definitely inherit a tendency or a deficit through your family lineage. The gender, men have a little bit higher occurrence with COPD, namely emphysema. And I don't know if that's because in the past more men have smoked. The numbers are not there to indicate that that is the reason. However, there is something in our genetic makeup, namely our genders, that makes us more predisposed to having this disease. So this is an x-ray, and we all know that we want to see black in the lungs because that means it's air. Of course, our lungs are full of air. Now, this person's lungs are incredibly distended. Typically, I would think that it would stop about here. But this person's lungs have inflated to the point that they are distended. So they are bigger, longer than they should be, which creates issue with exhaling. And that's why you see people that have COPD, typically they're going to breathe in and then it's hard for them to get all the air out because their bodies, their lungs, they don't want to squeeze as tight. It's hard. And so they have a tendency not to do that. Barrel chest is a physical characteristic that we see in COPD patients with emphysema. And it looks like a barrel. You can see how the anterior, so the front portion of the chest, and the posterior has kind of expanded, and that's to accommodate those larger lungs that are holding more air. Also with smokers, now these are extreme examples, we have digital clubbing. Okay, clubbing means that the end of the fingers are bulbous, okay, and that's just a side effect of continued ongoing smoking, oxygen deficits, and the way the body is reacting to that type of exposure. Cyanosis, so blue, cyanotic. It can be their lips, their tongues, fingernails, even the nail beds up in here. They have this kind of blue tinge to them, almost purple. And you see this gentleman here, his lips are purple, and that just means that the body is not distributing oxygen to the periphery or the outside. Okay, it's easier to pump blood and circulate closer to the heart. So as we get further and further away from the heart, namely our fingers, our toes, our ears, our lips, you're going to find that type of coloring because that body is struggling with circulation. Pursed lip breathing. These are folks that, again, are having difficulty exhaling. So they're going to take a deep breath in, as they can, and then when they exhale, their lips are pursed. It's like blowing kisses. And that creates a back pressure in the lungs so that it is easier to exhale and in turn inhale. We used to call them pink puffers. You see the puffer fish here because they just can't catch their breath because they can never fully exhale, which creates trapped air reflected in those chest x-rays. Shortness of breath is by far the most common symptom. Any kind of exertion or strenuous activity, doesn't even have to be strenuous. It can just be that they are walking. And if it is beyond the capacity of their lungs, we find that they become short of breath because they are at a deficit trying to regain that ability to move freely and easily. Coughing is a result of irritation in the airways. So if I cough, my body, all those little cilia are shaking, and now they're going to try and sweep out the mucus that is irritating the airway so I can expectorate or cough out the mucus. Bronchodilators are a medication that we use to help ease the discomfort with this mechanism, and also it helps to improve the patient or the person's ability to get rid of that stuff that's in their lungs. Now, does it ever really happen? No, because there's damage. But bronchodilators will dilate the bronchus, the bronchioles, so those upper airways that are constricted and irritated and inflamed, so that they can then move the air easier. And you find that in giving these bronchodilators, your patients with this obstructive airway disease they find a sense of relief with that. Steroids, just like you hear about with bodybuilders building all those muscles, we use steroids in the lungs as well. They decrease the inflammation that we've talked about, and they also can help prevent the flare-ups or triggers, whatever is setting you off to have this production of mucus, and then because you're at a deficit, difficulty breathing. Antibiotics is something that we hear a lot about. Recently, the goal is to not distribute antibiotics too much because of the concern that people will become resistant. Pneumonia would be one where there's fluid collection in the lungs, and then that can become infected, that you would need an antibiotic for. But in general, these COPD patients don't receive antibiotics. Oxygen is super common. Many patients end up having to utilize supplemental oxygen at some point, typically as their chronic disease continues to progress and their health deteriorates. They may need oxygen to help all the different systems in the body, especially exercise. Creates stress and strain on the body, and oxygen can help alleviate some of that. The pursed lip breathing, the blowing kisses. Breathe in through your nose, out through your mouth. Go ahead and try that. In through your nose, out through your mouth. Do you feel that resistance, that PEEP, that positive end expiratory pressure? That is what splits open the airways and makes it easier to breathe. Sometimes our patients actually have a buildup of carbon dioxide. Now, the reason I used monoxide here is so that people can relate that if you had a car running in a garage, you would not have a closed door, right? Because we all know that's bad. We have to open up the garage door, ventilate, and let out that bad gas. That's exactly what our bodies do. So in this case, carbon monoxide, if you weren't able to do that, you would slowly fall asleep because that bad gas is taking over all those little alveoli, and the cilia have become paralyzed, and you're no longer able to exchange the gases you need to sustain life. CO2 retainers, the gas that our bodies produce as a waste product is not carbon monoxide, it is carbon dioxide. And it works the same way. If you have too much carbon dioxide built up into your body, you actually will start to kind of get very sleepy, kind of goofy, and eventually you can actually experience loss of life. It's deadly. Now, CO2 retainers, that means that, again, you're retaining that bad gas, but not everyone with COPD retains CO2. So asthmatics, they don't have an issue with retaining CO2. They just cannot dilate their airways enough to breathe properly. So essentially burning is bad. Anything that's burning and going into your lungs is going to cause damage. It doesn't matter if it's cigarettes, campfires, people that consume anything else that you would burn and breathe in, you will have damage. 25% of the smokers don't realize that they already have emphysema, and so the goal is to stop smoking so that you may be able to retain whatever functionality you have left of your lungs and not create any further damage. Because the lungs do not regenerate. There's this common misconception that, if I quit smoking, my lungs are going to heal themselves. Those aren't the right words to use. The correct term would be, would no longer create and cause damage, and we would be able to retain the functionality of that system. So sometimes for super damaged lungs, they'll actually cut those bad parts out, because then in general the lung will become more healthy and it will function without having this big open sore. If you look at it that way, we just cut that out, and that's called a partial lobectomy. We could actually take out different lobes of the lungs, and they can still live a productive life. You hear about lung transplants where they actually take out kind of at that bifurcation where the airway splits, cut it out, and they'll actually suture in someone else's. There's tons of issues and complications with transplants, but if it's life and death, it's worth a shot. So again, it's not a death sentence. You can survive with COPD. There's plenty of people that do it. Emphysema is something that, again, we see in our elderly population, but I've seen patients as young as like 40, 45, 50 that for whatever reason anatomically they are more susceptible to that damage. You see 90-year-old people smoking cigarettes and cigars and they never had a problem a day in their life. It is all about your body. So it is definitely a gamble, and it is not worth it, because statistically the chances of you developing emphysema are very, very high. So I always like to kind of add a little quote that sticks with you, and my goal is that you might be able to remember Benjamin Franklin's words that an ounce of prevention is worth a pound of care. And what that means to me is, if you really care about yourself, you're going to think about the prevention of disease and deficit prior to actually having to deal with it. It's better, to make sure that you're healthy and maintain that, instead of saying, oh, this is what I'm going to have to do because of the choice that I made. We can't fix the damage of the lungs. All we can do is hope to move forward and be able to sustain the life that we already have. It's degenerative, so chances are, again, it's not going to get better, but you still have lots of life. The goal is to quit smoking or remove yourself from whatever environment is causing that, and then start a life where you're not exposing yourself to that. Thank you.